topic is individualized approaches to neurocritical care in comatose patients after CPR. I'll be focusing a little bit on temperature management and neurological prognostication. So these are my disclosures. I am the primary investigator of probably the largest trial right now on therapeutic hypothermia adaptive design in North America, which is the ICE-CAP study. I'll be talking a little bit about that, as well as the PRECISE-CAP study. I'll be talking about that. I also have a laboratory study based looking at mechanisms. All are sponsored by the National Institutes of Health. So the focus of my talk really is the post-cardiac arrest syndrome, which I've outlined here. So this is actually really convergence of about 30 experts in 2008, where we sat down and finally, after a long time since the development of modern CPR, agreed to define what happens after we have resuscitated patients. And there's really 4 key areas that we thought is important to focus on, especially in the critical care components. The post-cardiac arrest brain injury, which really defines the outcomes, and then the post-cardiac arrest myocardial dysfunction, which is a key factor considering that, you know, the heart is the main source for most of the injury post-arrest. And then, of course, the systemic ischemic reperfusion injury, which is critical to intensivists as well as whatever caused the cardiac arrest. And the key factor really here is that we know this, and it is getting stronger right now, that the primary determinant of function and outcomes is really what happens to the brain and how we protect the brain. And so with this as a backdrop, I'm going to start talking about how are we going to go about managing and approaching the brain injury, which is, you know, about 90 to 98% of all patients resuscitated after anywhere from 2 minutes of arrest time is unconscious. So it's a huge percentage. And this is where we get to the whole issue now of TTM. TTM is broadly used here as a targeted temperature therapy. Whatever temperature you choose, it's when you manipulate the temperature post-cardiac arrest. And the general trigger for all of the trials have been patients is generally unresponsive or comatose. It's not necessarily a GCS of less than 8 or 4 score less than 4, but generally speaking, it should be when the patient is unresponsive or when the patient is not able to give a meaningful response to our question, which is really indicative of brain injury. And what does this actually look like from the neurological perspective? So that is really a huge swath of clinical phenotype that we see in the ICU. But when you actually do studies on these patients, these are some of my patients that I took CT scans. So these are all unresponsive patients after cardiac arrest, all had CPR. Look at all of this imaging. So they really vary across significantly from each patient to another. But the thing is, we manage all of them the same way, right? It's like one size fits all in terms of the CPR that we do, in terms of the management that we do, and worse, in terms of how we prognosticate these patients. And so we're actually stuck. So going again to the theme of this conference is how do we learn now that, you know, there's a huge push on individual medicine and precision medicine. But the thing, so there's a lot of templates that we could use. And, you know, I'm glad to follow the talks. But one of the things that I think is very crucial that we have to learn that, you know, for example, cancer therapy. Cancer therapy is one of the very successful in terms of individualizing, right? They've gone down to molecules and matching molecules to the specific treatments. And it's successful. They're seeing success. But the problem there is for a neuro, like, for example, my field in cardiac arrest, also, it's all broad swaths of phenotypic approaches. And so that's where the problem is. And so, but in neurology, there's some areas right now that is starting to do this. And that area, for example, is in acute ischemic stroke. So part of the success right now that we see, for example, in thrombectomy, we don't just give TPA anymore because of a biologic clock that they're under 4.5 hours. What we're trying to do now is that very quickly when they come in, we image them. There's no bleed. If there's no bleed, we actually look for whether it's large vessel or small vessel. And then when we say it's a large vessel occlusion, after we give TPA, which is the standard of care, then we look for the particular vessel. So by looking for the particular vessel, in fact, what we're starting to do there is we are looking at the specific individual type of stroke, and then we open the vessel with the specific approach to that occluded vessel. So wouldn't it be nice if we're able to do that for other types of brain injury? But we're not there, right? So one of the things that I've been sort of passionate is this whole business of moving beyond one size fit all for patients after cardiac arrest. And so one of the things that I've done recently is I wrote the editorial to the article that actually came out of the Pittsburgh group, where the Association of Initial Illness Severity and Outcomes of Cardiac Arrest, where they actually did in terms of the decisions of the clinicians to put patients on 36 degrees versus 33 degrees. And when you actually look at that, there's a difference. But let me take a step back a little bit and just go on a quick tour on the clinical trials that's out there. So this is actually an important summary of the clinical trials that we have in cardiac arrest and targeted temperature therapy. So the key thing really here to see is that, and people have this total misconception right now that 33 degrees doesn't work anymore and only 36 degrees. That's absolutely incorrect, right? Because what happens, for example, with TTM1 and TTM2, TTM1 got so good that it almost came to the point of the benefit of 33 degrees, and TTM2 also with 37.5 is there, but none of these trials have shown to be superior, or none of these trials have shown that 33 degrees is not effective. It only shows that it is equivalent in the patient population tested. I have no time to go through all of this, but this just shows you that in all of this, it is very important to remember that 33 degrees has not been shown to be ineffective or inferior. And so this is going back to that article that I was saying from the University of Pittsburgh, where Cliff Calloway showed that when they compared their population of patients given 33 degrees and 36 degrees, they were similar. But when they looked at carefully, what they actually found was there was a stratification in patients depending on what they use this PCAC scale, which is really a mixture of neurological as well as the systemic severity. What they found was patients with PCAC2, which is like the intermediate level of PCAC score with coma and mild cardiopulmonary failure when you look at here. And what they found here was that it seemed to respond better to 36 degrees. And when they look at the sicker population with PCAC3 and PCAC4, that this seemed to respond more to the 33 degrees, better outcomes when they subjected to that. And here is just my own summary, because I just like people to actually really practice based on the evidence, that when you actually look at the stratification of cardiac arrest management, we have to remember again that no such thing as a one size fit all. So we have really to look at what is the cardiac arrest patient in front of us. First and foremost is that all of the trials that are out there right now are predominantly out of hospital cardiac arrest. So whether it's shockable or all rhythms, then we have to apply whether it's 33 degrees for 12 hours or 24 hours, or 33 degrees versus 36 degrees, or 33 degrees versus 37.5 degrees all Celsius, right? But then we have to look at the nuances of what are the patients that were treated by those interventions. And the key point to remember here, that in all of this, there's only one study that has been shown for in-hospital ICU arrest patients, and that is the Hyperion study, whereby they compared 33 degrees to normothermia, and 33 degrees was superior. So it's very difficult to tell people not to extrapolate the out of hospital to in hospital, but so many people do that anyway. So we have to be careful if we really want to do this. So that's just really, I think, a key idea that I want to impress upon the listeners. And I'll go back to that important paper with the TTM2 right now. And the reason why I'm saying this is that It's wonderful, and I really I applaud the study, but are they really presenting the same population that you are treating in your locality? When you look at the table 1 in TTM2, there's really a stark difference, at least with the United States population. And so you look at this, and here actually I tried to differentiate them. So is the TTM2 study population representative of your cardiac arrest patients? Think about this. The TTM2 has 80% males, right? Does that represent your population? I really applaud what they're doing in Europe, especially in Scandinavia, when they have 70% bystander CPR. What is the bystander CPR in your locality? In Baltimore, it's barely 30%. So shockable rhythm. So this is primarily heart, right? And the shockable rhythm is 72% and 100% of the etiology here. This is dramatically different from the cardiac arrest in the United States, where the shockable rhythm is barely 25%, and the vast majority of reasons for cardiac arrest in the United States nowadays is overdose. It's really your respiratory type arrest. And going back to this whole algorithm of thinking of individualizing, we cannot just solely apply. So the bottom line here is TTM2 may have worked on a population that may be less ill than the usual things that the usual patients that we see here in the United States. And this is actually the reason why when TTM came out first, TTM2 came out, people were asking us, should we still do the ICECAP trial? So we went back to the NIH and the FDA, and the argument really for us is that the TTM series does not represent the United States population. So we're still looking into this right now, and we are actively in this. So we have over 600 patients right now randomized in this. And what is ICECAP? So ICECAP study is really an adaptive trial design, looking at all of these durations of therapeutic hypothermia, 6, 12, 18, 24. And at any given point, there's 3 durations that the patients will get randomized. And as the trial keep going, so it's an adaptive Bayesian statistic-based study where we open up more arms that are longer if the patients are responding to the intervention. So this is, again, trying to get free ourselves of the one-size-fits-all paradigm. So in that editorial that I did for the Callaway article, this is what I wrote. We need to look beyond injury detection and look at clinical stratification. So, but what are the tools that we have, right? So we need specific biomarkers for the brain, and not only to predict long-term outcome, but also to look at specifically what is happening in the brain. Because right now, what we're really doing is we try to predict and then we withdraw care. And there's only one sure thing that's going to happen when we withdraw care. Patient's going to die. But we don't have ongoing real-time biomarker to help us assess our intervention is working or not. So we have to untangle these things. And this is from Karen Hurst and Jonathan Elmer. So this is the one-size-fits-all. Also, this is the United States, 600,000 cardiac arrests. 450 of those will die, but 150 estimated survive to hospital arrest, and only 600, about 90,000 of that. But the thing here's the issue: there's a huge proportion of patients that are potentially going to survive. But the problem here is that when you look at this, the vast majority of these patients die because of prognostication. So patients do not die anymore of the natural history. They die because we prognosticate them and we take them off the ventilator. And so I led this panel for the AHA. We looked at, together with Claudio Sambroni from Europe, we looked at all of the cardiac arrest prognostication studies as of 2019 and found that they are really, really dismally low quality. There is no blinded study at that point. Almost all of the studies were biased in terms of self-fulfilling prophecy. So if you're going to keep doing that, and we will keep quoting studies that are biased to start with, then we just reinforce this cycle of self-fulfilling prophecy by citing poor studies that were done prior. So this is the reason why we decided we will try to define what the standards for the studies of neurological prognostication ought to be moving forward. And I'm glad that the current studies right now have improved significantly. And these are the things that you could look into, and I just don't have the time to go into this. But the other thing that we're also doing, for example, in the Neurocritical Care Society, we have an initiative called Curing Coma. The biggest reason right now of deaths from coma is really prognostication and self-fulfilling prophecy leading to death. So here is just some example of the proportion deaths caused by withdrawal of life support. And it's just mind-boggling that 90% or 1/3 of the patients die because of prognostication in cardiac arrest. Similar proportions, really high also for traumatic brain injury, intracerebral hemorrhage, subarachnoid hemorrhage, as well as acute ischemic stroke. And during this period, the interventions that we've given have probably not even taken effect yet, and we're already predicting that they will have a poor outcome. And so this is from the NIH Resuscitation's Outcomes Consortium. The lead author of this is Jonathan Elmer. So they actually look at the outcomes of patients that had withdrawal of life support. Look at the purple. And so when you look at the first 3 days here, and it's just mind-boggling how much of the patients actually die. And when they projected the resulting deaths, about 2,300 of previously resuscitated patients that potentially may have an outcome. And while this is disturbing, there's actually a group in China that's doing this. And the interesting thing about the Taiwanese group, this study from Critical Care Medicine, what they did actually here is interesting, because what they did here was they had no limitations in terms of the length of care that they could provide for these patients. So they followed the patients for as long as they can. And what they found is up to 9.6% of cardiac arrest patients with favorable outcomes recover consciousness after the recommended 7-day of observation. So can you just imagine when we're treating like 600,000 patients, and 90% of those are non-responsive, and 10% of those we will have an error? That's a huge number. But I'm not saying we keep them forever. I'm just saying that maybe we just need to watch them a little longer. That's all I'm saying. And this, if you look at this article published in Critical Care Medicine, there are predictors of which are the patients that survive longer than 7 days. And one of the strongest things that came out really is therapeutic hypothermia. But then you say, wait. What are the other opportunities that we could look at? So when we actually start looking at clinical trials, so this has actually, interestingly, has gotten into the clinical trial design, right? Because if you're going to do TTM, you should not prognosticate earlier than 72 hours. Because when you look at the Nielsen study, they actually had a moratorium of prognostication and withdrawal of care for at least 72 hours. The arrest study with ECPR, Dimitri Yiannopoulos study, also 72 hours moratorium. And then the TTM2 study, they waited for 96 hours. So the ISCAP study, just to match this, we now actually protocolize no prognostication and active aggressive critical care for post-cardiac arrest up to 96 hours. But the sad reality in all of this, when you look at actually the graph, everybody, most of these patients have no prognostication until 96 hours. Come 106 hours, the prognostication shoots up. So it's still there. What I'm just trying to say here is that, and the sad part in this is that we keep getting negative. When you really think about this, TTM2 and TTM1 were really negative trials, right? They didn't show benefit of one over the other. And in critical care, it's the same thing. A lot of trials, especially in cardiac arrest, one after the other keeps failing. And one of the reasons why I think it keeps failing is that we actually never really get to allow the intervention to have an effect. Because most of these trials, we postulate would have a therapeutic effect of X, and then we would assess the impact at 90 days, and then we withdraw at 48 hours. So clearly, the intervention has not really taken effect, right? There's a different mechanism in terms of the actual neuroprotection in the acute period than in the functional outcome that we want to see. But I don't know, because I think we need wonderful biomarkers to help us. So I understand the struggles, because I myself am an intensivist. And when you're at the bedside, you say, so Romer, what are we going to do with this now? And because of that question, what we actually did for ISCAP, Karen Hirsch, who is a long-term collaborator, and Jonathan Elmer approached us and say, can we do a study within the ISCAP patients on prognostication? So I told them, look, if we're going to do another prognostication study leading to withdrawal of life support, I said, no, I don't want to be part of that. But here's the idea. If we could create parameters that would stratify patients and help us titrate what we have, then I'm all for it. And so what they did was, so they put together and submitted an RO1, which is what we call the precise cap. And what this is really to discover novel biomarkers and predict treatment responsiveness. So as therapeutic hypothermia is going on, we do these parameters and see which patients are responding. And so because ISCAP is multiple durations, so we're going to see some patients would respond to longer 33 degrees versus shorter 33 degrees. So that's what we're hoping for. And this grant got funded. And so when you look at this, so this is actually the preliminary data published by Jonathan Elmer. So as you could see here, there's actually really some, so the thing here is EEG suppression, and the blue here is the good outcomes. So you could actually, and the interesting part here is the orange and the yellow. Depending on the intervention, we could actually, hopefully, shift the curve to get to the green and the blue curves. So this is what we're postulating that we could do. And so the reds are really, there's nothing you can do with that. And what else is here? So when you look at this from a different cluster, looking at malignant EEG, as well as MAPs and other parameters, including MRIs, so you also have that 5 clustering, and the blue, the green, and the yellow are really what we're hoping for. And so this actually, hopefully, is a paradigm shift from the negative prognostication and the self-fulfilling prophecy, rather than it will provide us a guidance to keep going and provide, and it need not be therapeutic hypothermia. It could be whatever intervention that we could come up down the line, focusing on stratification and guidance of intervention rather than the negative aspect of withdrawal of life support in the immediate period. So this is part of the things that we'll be collecting for the precise cap study, critical care data, EEG, medications, imaging, and all of the other parameters. And we will do this. So this is primarily out of Pittsburgh and Stanford right now. And so this is actively going on. And the last 2 slides that I have, so what are we doing in the interim, Romer, you may ask me. So one of the things that we did was, because when you really look at post-cardiac arrest, outside of the TTM and outside of prognostication, there's hardly any RCTs in the management. So what we did was Karen Hirsch and I convened the thought leaders from all over the world in this, and then we came up with the post-cardiac arrest ICU management consensus conference. In 2019, we were already gung-ho, and then the pandemic happened, so we were delayed. But the thing is, right now, the manuscript is under review in circulation, and I cannot go to the details yet. But what it actually focuses on is, yes, TTM is just one aspect, but what are the things that we need to do? Early triage, how do we manage seizures, brain edema, ongoing hypoxia? How do we manage the heart? How do we manage the GI system? What's the oxygenation that is potentially advisable? And for the renal injury and endocrine, what are the other things? And patient and family-centric care. So this is all expert opinion. We did a modified Delphi approach, and this manuscript right now has gone through peer review, and we're finalizing it. So our hope is that this statement from a joint effort of the American Heart Association as well as the Neurocritical Care Society will come out in the spring of 2023. And this is my second to the last slide, and that is the wonderful, this is the ISCAP team in the bottom. and this is the precise cap. And as you see, we're climbing on ice. We still believe in 33 degrees. And this is my email. Email me if you have any questions. And thank you so much. And if I've gone through over time, I apologize deeply. And that's my last slide. Thank you so much for your attention.